is Misty Blevins with the National Rural Health Association, SC. I want to take this opportunity to welcome each of you to today's webinar, 12 Essential Steps to Building a Telemedicine Program. We are unable to provide CEUs or CPEs for this session. Certificates of attendance will be available upon request for attendees who register, attend the entire webinar, and participate in survey questions. Attendees may use these certificates with third-party organizations or their employer as documentation of having received an hour of webinar instruction. NRHA partner educational webinars are recorded, and an on-demand link will be sent in 24 hours to all who registered for the live webinar. Please note that throughout the presentation, all participants will be placed on mute. If you need to communicate with the webinar organizer during the session or have a question for the presenter, please use the question box at the bottom of the GoToWebinar control panel. We will answer questions after the webinar. I will now turn the presentation over to Carrie Dostie.
Thank you, Misty. I'd like to also personally welcome you all to our educational webinar today. Today's webinar is aimed to help you understand the full potential telemedicine can have at your rural facility, and more importantly, provide you with the 12 steps to help guide you through the process. Before we begin today, just to reiterate, as Misty kind of went over with the questions and answers, we will have that 15-minute Q&A session at the end of the presentations, so feel free to type your questions into the question box on the right-hand side of your screen, and we'll address as many as we can at the end. So today, we're going to cover a few points about how to get started with telemedicine and grow your program, and talk about the kind of 12 steps to get you there, what it takes to be a remote provider of telemedicine services and get the kind of physician's perspective, and understand the full potential and impact telemedicine makes at a rural facility for stroke patients. So today's featured presenters are David Johnson, the Certified Telehealth Liaison at Fort Drum Regional Health Planning Organization, and Dr. Jean Latore, the Medical Director at Upstate University Hospital Comprehensive Stroke Center. First, we'll hear from David Johnson, who will give you a quick overview about the telemedicine program that Fort Drum Regional Health Planning Organization has put together to help support rural community hospitals in North Country, New York. Then, David will walk you through the 12 steps he has used and found successful for his 22 telemedicine projects. David?
Well, thank you, Carrie, and thank you to all of you who are participating today. Let me just clarify a little bit that what I'll be sharing with you today are what I call 12 profoundly simple steps to establish telemedicine projects, but they are not easy. Profoundly simple, but not easy. So building telemedicine into your organization takes a tremendous amount of persistence, dedication, collaboration, just plain boots on the ground hard work. And so to give you a picture of that, let me introduce you to the Fort Drum Regional Health Planning Organization, or what we call FDR-HPO. FDR-HPO was initially established in 2005 to bring Fort Drum Medical Command officials together with regional healthcare providers and really plan for a huge population growth resulting from an additional brigade being brought to Fort Drum. So our mission is to strengthen healthcare for Fort Drum soldiers, their families, the surrounding civilian community, and we do that by analyzing our healthcare system, identifying gaps, and leveraging resources to fill those gaps. We don't provide direct patient care, but right now we are the lead agency for New York State's Delivery System Reform Incentive Payment Program, or DSRIP, the Population Health Improvement Plan, and many workforce development initiatives in the North Country of New York. So as it relates to telemedicine, to give you a perspective of the amount of hard work that has gone into our telemedicine project, In 2009, the image that you see on your screen right now represents the North Country Telemedicine Project's fiber optic network connecting healthcare sites across the region. So in 2009, we received a $1.9 million FCC award, and that's what built the infrastructure there, connecting primary care sites, regional hospitals, and many tertiary facilities in, like, for example, Upstate Medical, who you'll hear from later today. That largely covered the western portion of the image that you see there. And in 2010, FDR-HPO assumed responsibility for what's known as the Action Network. That's the Adirondack Champlain Telemedicine Information Network, and that covers what you see on the right-hand or eastern portion of upstate New York. So we worked actually to develop a cross-connect combining those two networks, and now there's over 100 sites connected on our network. That network is important because of the audio and video data that we are pushing through the system for telemedicine. So with all that infrastructure in place, by 2012, we began to really go after what are we going to put on our fiber network. And of course, first through grant funding, our PACS system with radiology, the original adopters of telemedicine applications, we started there. And then began to work on secure video conferencing. So we purchased equipment for video teleconferencing and multi-point control. And initial discussions started to take place on connecting primary care offices and regional hospitals. So with all of that infrastructure in place, you might ask the question, well, why didn't telemedicine take off? And primarily the answer is because of issues surrounding reimbursement in New York State, but also challenges around credentialing, changing workflows, changing perspectives about how we do delivery of care. So still we pressed ahead. In 2013, our first telepsychiatry patient was seen. And then this is when, through further grant funding, we secured AMD Global Medicine mobile telemedicine carts. And AMD was tremendously flexible in working with us. I think that we actually had a part in the design of the dual monitor carts that are available from AMD. We placed both single monitor and dual monitor all-in-one systems in 7 of our regional hospitals. And now, is sometimes the case with technology and the way grant funding financing works, we actually had a solution ahead of a problem. Trying to advance that slide, but can't seem to do it. Carrie, can you help me out there? There we go. So in 2014, through Rural Health Grant Funding, FDR-HPO hired a telemedicine project coordinator. That's me, and I'm glad to be here. We established a teleneurology project connecting the University of Rochester Medical Center with one of our skilled nursing facilities for Parkinson's disease patients. We continued to expand telepsychiatry with our corrections facilities, and we facilitated what we've come to call a telemedication reconciliation project. That's not easy to say, but it's a powerful tool. In 2015, through further rural health grant funding, we hired a telemedicine project coordinator to cover that Adirondack region. And this is the year 2015 when we established the telestroke project with Upstate Medical, which you'll hear about more shortly. In 2014, we began to track our patient encounters. And in 2014, we tracked a total of 40 patient encounters, which is not all that impressive, but I take some encouragement from the work that the Georgia Partnership for Telehealth has done They started out very similarly, and last year I think they did over 200,000 patient encounters. So we're on the right track. As it works out, even this morning as I checked, year to date we have 23 active projects. As of this morning, we tracked 600 patient encounters year to date, so for a total cumulative of 955 patient encounters. You may have noticed on a previous slide, too, that we've had some limited experience with remote patient monitoring, and we hope to develop that further in the coming years. So how does all that year-over-year impressive growth, if you were investing in a stock, you'd invest in us, how does that happen? Well, as I said earlier, it takes a tremendous amount of persistence and collaboration. So what we wanted to do was make it as simple as possible for our partners. And so we use these 12 profoundly simple steps. They're simple, they're not easy. And for the next several minutes, I'm just going to walk you through just a few insights from each of these steps. We said that the first step should be defining the needed service. Ideally, this step would be done long before any equipment was purchased. Today, I'm working with about 90 different sites, from hospitals to primary care offices to FQHCs, community-based organizations. And the first question I ask is, what do you need? And so here we're looking at referral patterns or departments with patients who visit frequently, like psychiatry. What are the specialties that are really needed but hard to gain access to in your region? And then the second question I ask is, what can your organization provide? What are the specialties that you could really develop and expand the reach of in your region or perhaps across your state through the use of telemedicine? Once that's nailed down, we move on to the second step, which is finding specialists. This is probably the most difficult in our experience, somewhat because of our own parameters. We wanted to work as much as possible with regional and statewide partners. And these people resources in rural upstate New York are heavily burdened, as most of the 11 counties that we serve are healthcare provider shortage areas. Even some of our more closely connected urban centers, like Syracuse or Rochester, Albany, they really have the sense that they can't take on more than they're doing. So we've had to demonstrate the power of telemedicine to increase efficiency for those specialists and at the same time improve access to care for patients. Another thing I'll mention, because I know there are several telemedicine providers on the call today, is that we looked for providers who would take on billing. We've actually created a workflow visual for presenting sites and compared that workflow to specialists. And when you look at that graphic, you begin to see how much work a presenting site has to do to make it possible for a specialist to connect remotely with their patient. And so to ask these presenting sites to take on additional work of billing seems like a barrier, seems like a hurdle. Now, for our hospitals, the incremental cost of billing for telemedicine may not be significant, but certainly this is a barrier for our primary care providers and primary care offices. The next step is pretty straightforward. Connect the spoke hub and the spoke site and the hub site together, connect their staff. Here, you've probably heard this before if you've had any encounter with telemedicine before, but you want to make sure you have your clinical, your IT, and your administrative champions involved from the beginning. Our experience was that we actively engaged with our IT champions, but we didn't really have the administrative and clinical champions involved at that point. Once the infrastructure equipment was in place, we really couldn't move beyond that without engaging clinical and administrative champions. But with those people engaged, telemedicine begins to take off. The next step was, in our minds, to select a program start date. This just adds some urgency, accountability to get things done. You might recall that the famous Zig Ziglar says, if you aim at nothing, you will hit it every time. So we wanted to take aim at a start date. If everything is working perfectly, your organization should be able to move through these 12 steps in about 4 to 6 months. Of course, everything doesn't always work perfectly. So let me mention here that some of these steps can be worked on concurrently, and you'll see a little bit of that as I continue here. The next step we say was logical was the equipment acquisition and preparation. Now, again, in our situation, because of grant funding, the way purchasing worked, we really had a solution before we had a problem. We had the equipment before we had to develop the use cases. So I encourage you to learn from us in this. It's really better to contact AMD Global after you've done at least the first 4 steps. What are you going to do with the equipment? Do you have the specialist to provide care? Are the hub and spoke connected, talking with the right people, and have you selected a start date? If you've taken those steps, you'll know exactly what you need to accomplish your goals. Concurrent with these earlier steps, you can also begin completing appropriate paperwork. And here we're talking about licensing and credentialing, MOUs, making sure that all the appropriate billing pieces are in place, making sure that you're complying with your state health department requirements or OMH requirements. In New York State, for example, an OMH licensed facility needs to have approval from their field office to provide or receive services via telemedicine. So you got to work on those things. And in a similar way, you'll want to begin working on your internal policies and procedures, which kind of leads us to that next step, step number 7, refining policies and procedures. We say here refine policies and procedures because we actually provide templates to our partnering organizations to help them get the ball rolling, to get them thinking about what they need to be working on. These policies and procedures will cover things like what's your referral process, what paperwork will be required, will you require a specific telemedicine consent form, which may be required in your state? Will you provide patient educational materials on telemedicine? How will you handle scheduling, cancellations, no-shows? By the way, on no-shows, out of the 955 tracked patient encounters we've had, we've only had 6 no-shows, so that's pretty powerful. Other things you might think about are how will you handle the physical surroundings, the equipment, staffing, and then maybe most importantly, what are your security and emergency protocols? And many other pieces that you'll want to take a look at. The next step is to move toward equipment drop-off, room setup, and test. And this is where you're basically implementing the guidance of your policies and procedures regarding the physical environment and the equipment that you're using. And it's where you'll begin to test the equipment. This is also the point where you're going to want to receive training on how to use the equipment, get familiar with it. And once that's complete, then you can actually move on to scheduling a test patient. Maybe it's going to be a few patients, a number of patients. But you'll want to find patients who are willing to play a little bit, who understand that there may be hiccups here and there. So you'll want to schedule a test patient who wouldn't get rattled if a connection failed for some reason, or you forgot to change the otoscope battery or something like that. After you've scheduled the test patient, now you'll test the process from the beginning to the end, from scheduling to receiving the patient, to connecting with a specialist, to billing, scheduling, follow-up appointments. You've walked through the entire process. So through that testing process, you'll be asking, what's working in this? What's not working? Are we ready? And then once you've tested, and what I like to say, you're at least consciously competent with the process, go ahead and commence the program. Go live. Market what you're doing. People are interested in telemedicine. Our local media has been a great partner as we take small steps to build telemedicine in our region. And then the final step is to evaluate and adjust. Here's where you want to formally bring back your clinical administrative IT champions together with some involved staff and ask again, what's working, what's not working, how can we improve this delivery method of care? So there are your 12 essential steps, profoundly simple but not easy. Some of the things that are next for us in the next few months, we'll be launching a telewound care project, which will involve the peripherals that Carrie will be telling you about later. Teleendocrinology is on the horizon, and in the coming year, we're focusing on the integration of behavioral health and primary care. We hope to launch a teletrauma project across the region later in the year. And with all of that said, I'll turn the presentation over now to Dr. Latore from Upstate Medical.
Thank you, David. Good afternoon, everyone, and thank you for attending this webinar. And thank you, Carrie, for this opportunity. I have three things I would like to share today. And the first is the concept of telestroke, give you some perspective on how we do it and why we do it. And the second is how to do it as a provider, being a remote provider of the telemedicine service. And the third is sharing you some patient stories on how this process has saved and changed some of our patients' lives. So, as Dave has mentioned, there are several telemedicine platforms, and there are telemedicine that involves outpatient, non-emergency setting, where you have a patient encounter that gets scheduled. This type of telemedicine that I'm talking about is the telestroke, which is an application of telemedicine in an emergency situation. Telestroke is a form of telemedicine where a specialist is brought to the patient's bedside using our current technology. And hopefully in the subsequent future, we can actually have a teleportation that we can have the specialist physically be at the bedside. But for now, we can just have them be there using the video technology. In telestroke, the consultation is done through the internet connection. The patient who is having a stroke will go to a local community hospital that's connected to a hub hospital, and the hub hospital then connects to the specialist, who can be anywhere from 100 to 200 miles away from the patient. And within a split second, the patient is connected to the specialist, and the specialist can pretty much do everything that the specialist needs to do, as if the patient is at his side. Through the help of the local hospital staff, the specialist can examine the patient and determine any specific intervention that needs to be done. The telestroke that we are doing right now is currently limited to patients who come to the hospital with a last known well of about 6 hours from the time that they either start having symptoms or the last time that they were seen well. We also look for a CAT scan that does not show any hemorrhage, and a patient with persistent symptoms, and we use the NIH stroke scale, which is a scale that we do to determine the severity of stroke. Patients who are not meeting this criteria will have a regular phone consultation. The reason why we do this is because with the telestroke, we want to determine whether the patient is eligible for acute intervention. Without this criteria, most of the patients will not be eligible to acute intervention such as intravenous TPA or the clot busting medication. And so we are not pressed for time, and so we can do just a regular phone consultation. So this is what we are doing through telestroke. When the patient gets connected to the specialist would examine the patient as if the patient were present beside him. The patient will see the face of the specialist, and the specialist will see the patient. The neurologic examination is done. A CAT scan of the patient is also available to the specialist for review. And if the patient fits the criteria for somebody who can get this medication, then the specialist would recommend this medicine to be given to the local physician, who will then administer the medication. So why are we doing this? Well, stroke treatment is very time sensitive, and as you probably all know, time is brain, and about 2 million brain cells die per minute. More than 1/3 of the US population are more than 1 hour away from a primary stroke center. And at upstate, especially in central New York, the proportion of population that are more than 1 hour away to a primary stroke center is actually more than 50%. And so there is a lot to gain for local hospitals to have a telemedicine connection to a primary or comprehensive stroke center, so that their patient doesn't have to be deprived of this life-saving and life-changing medication through the acute intervention with stroke. So, being a provider of telemedicine, it takes some commitment. If you are in covering a telestroke, you will need to be available 24 hours a day, 7 days a week, and we typically do this rotation about 1 week at a time. When you are not in the hub hospital, then you have to carry a laptop with mobile broadband connection that you can open and connect to the patient very, very quickly. If you are inside the hospital, we have a couple of telestroke stations that we can get into and log in within 5 minutes of the telestroke request. During the consultation, we access the patient, we look at the CAT scan, and we access the spoke telemedicine card, and that's where we see the patient and we examine the patient. And we also record our consultation through our electronic medical record, and this record will be faxed directly to the spoke hospital for documentation of the telestroke consultation. This is also where we get the documentation for billing purposes. So let me share you a couple of patient stories that we have recently managed through telemedicine. The first patient is an 87-year-old female who complained of difficulty talking with right-sided weakness. The symptoms started on May 29 at around 6:50 p.m. And the patient was immediately brought to one of our spoke hospitals at River Hospital. Within a short period of time, a CAT scan was done, and they thought that the patient fits the criteria for telestroke consultation, so they called us for telestroke consultation. Within a short period of time, we were able to evaluate the patient, and the patient fit the criteria for intravenous TPA, and so it was recommended, and the patient received TPA within a short period of time, and we recommended that the patient get transferred to the hub hospital for additional workup, and further management after the TPA. The patient arrived shortly after midnight, and we did some workup. And after 1 week of hospital stay, the patient was discharged to rehab with improved symptom. This is the MRI of the patient, and you can see on the left side of her brain a very small stroke. The patient had a big clot in her left middle cerebral artery that supplies majority of the left side of the brain in this area. And had she not received the TPA, she would have infarcted this whole side of her brain, and she would have been left with significant paralysis of her right side and inability to speak. So this patient went to rehab with improved weakness and improved ability to talk. This patient, the River Hospital is about probably more than 100 miles away from upstate, and without a neurology consultation through telestroke, they would not have the ability to give this medication. The second patient is a 66-year-old male who had a left-sided weakness and difficulty with speech. This symptom also unfortunately started beyond 4.5 hours, and so the TPA could not be given. We found out that the patient woke up with a symptom, and so through telemedicine, we decided that the patient should go urgently to the hub hospital, which is upstate, and true enough, we found a large vessel occlusion, and the patient underwent an emergency mechanical thrombectomy, which is a procedure that we do to similar to what you do for the heart when the heart is having a heart attack. So we put a catheter to get the clot out, and this patient had this procedure and was discharged to rehab after a couple of days in the hospital, also improved. So this is the cerebral angiogram of this second patient, and you can see here that there is a cutoff of a big clot that is blocking the patient's right middle cerebral artery. And within minutes of catheterization, you can see over here that all of these blood vessels that were not having any blood supply because of the blood clot were opened by that simple catheter procedure. And the patient improved significantly and was sent to rehab with potential for significant recovery afterwards. So this is how we do telemedicine through our telestroke program, and so far we have treated a number of patients who would not otherwise receive this emergency treatment had we not have a telemedicine network.
Great. Thank you, Dr. Latore, for sharing your perspectives and patient stories, and as well for David for sharing the 12-step program. David and Dr. Latore touched on so many great points on how to make telemedicine programs successful for rural hospitals. Before we move into the Q&A session, I would like to quickly touch on the telemedicine equipment and technology preparation steps that David spoke of. As David mentioned, in his 12-step program, telemedicine equipment is a key component in 2 out of those 12 steps. So here are some key takeaway points regarding telemedicine equipment and technology. So the first is what types of equipment or technologies are available. Every situation has a unique set of specific needs, but for the types of telemedicine consults that Fort Drum Regional Health is doing and that David spoke of, these are some of the types of equipment. They break down into basically three categories. The first is encounter management software, and this allows the clinician and remote physician to conduct a real-time patient exam and then communicate live medical data and images during the consult. The second is medical devices and equipment, also referred to by many as the peripherals. And these are things like stethoscopes, examination cameras, ENT scopes, ECGs, vital sign monitors, dermoscopes, and the list goes on. And all of these basically collect that the diagnostic patient information and, again, share it over to the remote provider. The last area is the packaging, and this pretty much can be almost anything, really, from mobile carts, wall mount systems, desktop units, portable cases, and these are all based on your application needs, where the equipment's going, what you're going to be doing with it. So finally, the second key takeaway point here is that there are some considerations to keep in mind when choosing your telemedicine equipment and technology. And if you have done the first 4 steps, as David outlined, this process will be much clearer for you to define. For example, medical specialty servicing. So what are you looking to provide, not just now, but also think about what would help in the future as well. And look for equipment or technology that is modular and can scale with you as your needs grow and evolve. And of course, training. So what training is required of users? You know, finding a technology that is easy for people to use will make them want to use it more. Integration with existing IT infrastructure. So you don't want your telemedicine services to be a complete separate practice of care. It should be easily streamlined within your existing practices, workflow, and the rest of your technology. So if you can possibly leverage your existing technologies that your organization may already have, then finding other things that supplement or work well with that and integrate with that will help you go a lot farther. And finally, the environment of the equipment. So does it need to be mobile, move from room to room, or set up and left in a dedicated room and be ready to go at a moment's notice? So this will help you determine kind of the type of packaging you need. And so now it's time for our questions. And if you have any questions at this time, some of you may already added some to the question box. Go ahead and feel free to add in any additional questions you have. Just give me a moment to pull these up. Okay. Okay, let's see. Somebody, David, this might be a question for you, had asked about reimbursement and if you get reimbursement for any phone consultations or even if you're doing any phone consultations at all.
Nope, primarily we're using the video conferencing, and so that's reimbursable. There are, in New York State, there are a host of different rules about how that works. So our Medicaid program essentially will reimburse. Medicare, as many of you know, at this point is only reimbursing in non-MSA or non-metropolitan statistical areas. So one of the workarounds we've had with that is our one major county, Jefferson County, is considered a metropolitan statistical area. So we'll try to get patients over to a county next door to see that that gets reimbursed for Medicare. Many of the private insurances in New York State are reimbursing. We had a parity law that was passed. It's a coverage parity law that went into effect at the beginning of this year. But some providers or some insurance companies, private insurance companies, are looking at how that's actually going to work out. So we're waiting for some regulations to come from the Department of Health.
Okay, great. Also, another question for you, David, is somebody was asking a little bit more about the policy and procedures templates that you came up with and what types of information that might include.
Well, I think I kind of gave a list of some of the things that are there in the presentation a little bit. Those, we're a grant-funded organization, so if you want to send me an email, I certainly could even provide you with a template. But there are things like, what's the referral process? what paperwork is required, how you're going to handle scheduling, cancellations, no-shows, how do you, maybe most importantly, handle security or emergency protocols. So those are some of the things in our policies and procedures.
Okay. Another question was, what, in your case, David, you found as the main barriers to implementing the telemedicine programs?
I'd say that the two major barriers, at least for New York State, first has been reimbursement. There wasn't a huge incentive for specialists to engage with telemedicine. And then secondly, that issue of finding specialists. So finding the providers, willing to try something new. Also having the capacity to do something different. So having a specialist like Dr. Latore is a huge win. And then, in our case, the issue around specialists largely was, are they willing to take on billing? So those are the two major barriers, I would say: reimbursement, finding specialists. Great.
And I know, actually, there's a question here about nursing home and skilled nursing facilities. I believe you guys have done some things in that. And there was a question here about, do you have any experience with nursing home patients to prevent bounce back or to improve quality of life?
We have some projects around telepsychiatry in skilled nursing facilities. So that's a big win. There's a huge need in that area. And in that case, we're actually using a vendor. We also have the Parkinson's disease project with the University of Rochester Medical Center, and they're specialists there.
Okay, great. Also, here's another question, David, for you: is which step do you consider the most difficult to establish, and how long can it take to implement the whole program? I know you did mention the entire program takes about 4 to 6 months, if given everything's in place. But do you want to expand on maybe which one you find the most difficult? Which step?
Yeah, I think I would say that finding the specialist is the most challenging for us. The other pieces seem to work out pretty well. It's not hard for an organization to determine what their need is, whether they want to access care, they know those needs that they have, or once they have a specialty that they want to expand, even if they want to do that, sometimes the specialists are just saying, hey, I'm doing enough. I'm working hard enough. And they are. So it's difficult finding a specialist willing, having capacity to do it.
Great. Okay, here's another one. Due to HIPAA laws, how does an emergency doctor access patient medical history in a satellite hospital?
In the case of the stroke patients, maybe Dr. Latore, you could answer that question.
Yeah, so the way we do that is by having the specialist be part of the credentialed provider in the local hospital. So, every patient who gets admitted to a particular hospital signs a consent for release of their information and the use of that for patient care. And so, remote providers become part of the staff of the local hospital, and that allows us access to HIPAA-protected patient information.
And that's actually a requirement in New York State that they be licensed and credentialed in the facility.
Here's a question, sounds like about the network connection, but not quite sure. It says, please talk about your communication links, the capacity and speeds, and did you buy dark fiber or LIT services?
Boy, I wish my IT guys were on the line to answer that one. I'm not entirely sure which or what that is. I know that we have a 100 gig connection to our major hospitals, and then I think it's 50 for primary care settings.
Just another question about telemedicine services, and this would be, I guess, providers. So you might have somewhat addressed this, but it's asking, is having a dedicated telemedicine network superior to using services like telemedicine service providers, and why? Why, in your mind, do you prefer having your own?
So definitely we're not opposed to the idea of working with vendors, but I think just kind of the tone or the sense of our regional partners in the North Country is we want to work with people that we know, work with people that we know that the patient could make it to see that provider in person, not just telemedically. So that was kind of our initial focus. Now, because finding specialists has been a huge issue for us, that's been the major barrier. I think we are, considering and looking at providers outside of the region.
Okay, great. Another question about reimbursement was more if there was reimbursement for the originating site and how that works.
Yep, presenting sites can also bill for a presenting site fee. It's usually really small, $15 to $25, something like that. So that's why we try to encourage the specialists to take on billing.
Okay, looking through just a moment, see if there's more questions. Oh, have you ever considered doing teledermatology as an opportunity or a service to provide with telemedicine?
Yes, that would be great. Love to do that. In fact, we have talked with some dermatologists who have shown some interest in that area. The difficulty, again, for us has been having the dermatologist take on billing. So what the folks that we've worked with typically have said is, we'll be available. We'll do this. We'll read the scans, read the images, but we want you to pay us a monthly fee or work on a contract basis. And that typically for the facilities that I'm working with in this area, that's where they go, yeah, maybe not. So.
Okay, great. I think that might be the end of the questions. If anyone has any more questions, please type them in now. All right, it looks like that will be it. Here's the contact information, which we'll also provide following up with the webinar. We'll provide a copy of the slides, a link to the recording, as well as the contact information for each of the presenters in case you want to follow up with some additional questions or reference points. Thank you very much for attending, and we look forward to seeing you at the next webinar. Have a good day.